rule.
There's so many.
Yeah, there are. And the one I would be more concerned about are the ones that would interact with Coumadin or warfarin. And those are things you're going to check anyway. That's the things that the pharmacist is going to check.
Okay.
So it's one of those things that unfortunately, it's going to be something that, if they're on multiple medications, you can put all of them in Micromed-X and it will tell you if they're interactions.
Yeah.
Because God knows you can't remember them all.
No. What about like interacting with each other, like the benzodiazepines with the hydatoins? Like, how phenytoin interacts, like the barbiturates can increase the levels, like that kind of thing?
Yeah, I would sort of think about those types of things. One of the things that you'll see with multiple patients on multiple seizure meds, okay, is this. Like I said, a large number of people do not do well with just one medication. They have to go on what we call polytherapy or multiple, okay? So one of the things that you're going to have to think about is that if I am on 2 of these seizure medicines, even though I have been, say, for example, they're on one of the phenytoins, okay, and their drug level has been therapeutic, and you start them on another medication, I would check both levels because there is some interaction there with those.
So, for example, say my patient is taking phenytoin, and then they have a status epileptic episode, and I give them the benzodiazepine. I need to check their blood levels for the phenytoin because it can be increased from the benzo.
Well, it can, but more than likely the reason that they were having status is their level was not high enough to begin with. Okay.
You may need to increase their phenytoin level.
Correct.
Okay.
So that would be one of the things that I'd worry about. Now, when you're talking about interactions, I would worry about like the benzos and like the barbiturates. Okay. Both of them are medicines that are going to cause sedation and can cause respiratory depression. So if you've got patients that are on both of those, or if, say, for example, they're on a barbiturate and you have to give them a benzo because they're going for an MRI and they don't do well with enclosed spaces, you need to make sure that you watch that patient for respiratory depression.
Okay.
Thank you. The things that you worry about more would be, does it affect therapeutic levels of other drugs? And it may. So typically what we do is when we start someone on another drug and they've already been on therapy with the one and it's been therapeutic, you will go ahead and draw blood levels of both because there may be an effect. It may increase, it may decrease that medicine. Okay. Now, if I have had this patient and I'm doing a complete switch, like they were on a phenytoin and they want to switch them to like valproic acid or Divalent sodium, okay? Then remember, with some of these medications, you have to taper them. And then build up with the other. So you may give those 2 medicines concurrently and hope that you see a decrease in the one that you're discontinuing and an increase to therapeutic level in the one that you are starting them on.
Because if you don't, they could have an increased risk of having a seizure.
Correct.
And you don't want that breakthrough.
No.
In therapeutic level.
No.
Okay.
And typically what we, it's not safe to stop these suddenly in any patient if they've taken them more than 3 or 4 days.
Okay.
Okay. The thing is that a lot of these patients will be on these medicines from whenever they start having seizures to the rest of their life. So it's one of those things that you have to be very careful and check those therapeutic levels. Anytime you change a dose, anytime you change like a brand, like going from those generic to another generic, or going from brand name to generic, okay, you need to check levels and make sure. Now, the other thing, of course, you need to make sure about is what other labs might you have to check. Probably liver function.
ALT, AST, BUN, creatinine.
Correct. Those types of things. Okay.
Thank you.
But no, don't worry about, I just put it up there just to give you a little bit of a flavor. I mean, seriously, if you are to try to remember all of the drugs that interact with warfarin, okay, that would take the rest of your nursing career. The last time I checked, there were over 750 drugs that either altered the absorption or secretion of warfarin. And there's no way. That's what Micromedics is for. That's what that computerized system is for, to help you with things like that. And hopefully your patient's going to the same pharmacy to get their Coumadin prescription filled as they are with any of their other meds. But unfortunately, that may not be the case, because a lot of times what you'll find is that people go where it's cheapest. So there may be some meds they get at Walmart or Walgreens or CVS on that $4 list. And then others that they get either by mail order, or when the doctor calls in like 1 week's worth of medicine, they may go to, a hospital pharmacy. And so there's no intermeshing to check for those
interactions.
Okay.
Thank you so much for that clarification.
Yeah, you're welcome. I will tell you guys, it's, with seizure patients, they are especially prone to having those interactions. As I said, they could start having that seizure disorder when they were a teenager after head injury. And if they live a fairly long life, as they age, they're going to add more and more medications. And so the thing that you're going to think about is going to be making sure that they understand that even over-the-counter stuff can cause interactions, okay? especially if it's cough, cold, or flu meds, okay? Those antihistamines or decongestants, not only for seizures, but we'll talk about some of those whenever we talk about some of the eye disorders with glaucoma. The Lord only knows. What you'll see is that every medicine, do not take if you have glaucoma, because there is a chance that it can cause further damage to the eyes because of the increased pressure. Courtney, your cat's having fun here. Mine's over here asleep. All right, so let's record. And there is a question. It says, I understand any of the material covered is fair game for the test, but I noticed ear and hearing issues weren't listed on the blueprint. Actually, they are. That's the Meniere's disease, okay? So the questions that I will ask related to hearing and ear issues are going to be Meniere's, because that's probably what you're going to see most often with these patients, okay? And it can be a big safety issue. All right, so I'll sort of pick up where we stopped. Basically, last time we had sort of finished up with the AMD, and we're moving into the diabetic retinopathy. Okay, so what we've got here is diabetic retinopathy is one of the most serious vision-threatening complications of diabetes. One of the things that you'll see is that it is the most common cause of blindness in your patients with a history of diabetes mellitus. Now, there are 4-stage, mild, moderate, severe, and then proliferative. But what I want you to understand about this is that what occurs with your patients with diabetic retinopathy is that they have blood vessels that are blocked, the ones that nourish the retina. And so new vessels grow. And unfortunately, what happens is those vessels are fairly abnormal and they leak, and it can cause edema of the retina, okay? So, there are about 18 million people in the adults in the United States with diabetes. About 30% of those are undiagnosed. Now, one of the things that really is sort of scary to me is we are starting to see kids as early as 6 and 8 years old with type 2 diabetes. Typically, we haven't seen type 2 diabetes in patients until they reach their 50s or 60s or older. But we're seeing it in kids because of obesity and lack of exercise and poor nutrition. And so this is a disease that you may see rapidly increase in the future. One of the things you'll find is that diabetic retinopathy, or DR, affects about 50% of people with diabetes. Now, what you will see is that about 26% of those with diabetes for 25 to 50 years will develop it, okay? One of the things that you'll see is that the development of diabetic retinopathy is correlated to the length of time that you have the diabetes. One of the things that, as I said, you get that proliferative retinopathy, those fragile vessels, they hemorrhage very easily. that blood leaks into the retina, into the vitreous humor, and it causes spots or floaters. It also causes decreased vision. That macular edema can occur at any stage, though it's more likely to occur in that severe to proliferative stage. When they develop that macular edema, it blurs their vision. What you see with this slide is that you may get what we call these cotton wool spots, okay? These are old areas of hemorrhage that basically heal with areas that appear white on those retinal pictures, okay? In that proliferative stage, you see a lot of growth of these abnormal vessels. And so this is one of the reasons why it's very, very important to do that retinal photography, okay? Here again, you can see those very large areas of hemorrhage, those cotton wool spots, that vessel. There is some edema here as well. The duration of the diabetes is the major risk factor. Typically, retinopathy is rare within 5 years of onset of type 1 diabetes, but what you will see is that the risk increases thereafter. Typically, the prevalence of the retinopathy in adults using insulin at 5 years after diagnosis is about 40%. And if they survive to live 15 to 19 years after their diagnosis, that incidence increases to about 84%. With our patients with type 2 diabetes, about 23% have diabetic retinopathy after 11 to 13 years, but after 16 years, about 60% have it. So if we've got an 8-year-old that's developed type 2 diabetes, when they're in their early 20s, the chance of them developing that retinopathy is greatly increased. Now, there is a risk factor for diabetic retinopathy with poorly controlled blood sugar levels, meaning that they don't follow their diet, they don't take their medication as ordered. But guys, I'm going to tell you, it even happens with patients that do have good control. Of course, the better the control, the less the risk, unless you get up into the category where you've had it for 15, 20, 30 years. Again, that duration is one of the major risk factors. Others are going to be high blood pressure, high serum cholesterol, obesity, kidney disease. Now, what about pregnancy? Why would pregnancy increase the risk for diabetic retinopathy?
Because they have more blood flow or more blood volume, so their blood pressure is already increased.
That is correct. And if you think about it, to handle that increased volume, the body grows extra blood vessels anyway, okay? So one of the things that you will see is that women that are pregnant that also have diabetes definitely need eye exams every 6 months or more often. Typically, what you will see is that patients that have diabetes should be examined every 6 months because of the risk for diabetic retinopathy. But pregnant Women, maybe every 3, depending on what their previous eye exams have shown. Now, what does it do on vision? Typically, you see decreased fluctuating, meaning it changes. Sometimes it's very sharp and sometimes it's very blurry. You often get distorted vision. People with diabetic retinopathy have problems focusing because remember, with that macular edema, the images are not sharp on that retina. Typically, they have a loss of color vision. Everything seems washed out. They also may have floaters, and typically that's due to the vitreous humor thinning or having debris or even blood in it. Classic sign of diabetic retinopathy, guys, is Swiss cheese vision. That's Katie. That Swiss cheese vision is very similar to what you see with Swiss cheese. The holes are all over. Remember, with AMD, it was a central loss. But with diabetic retinopathy, you can see these splotches here, or the black spots. That's where the vision loss is. This is early with the flower. These children's faces is much later. And you can see that the vision basically is gone behind these spots. Now, how do we evaluate these patients? Very similar to most eye exams with the retinal photography and the visual acuity test. Additional tests that we will do with these patients are fluorescein angiography. And that's sort of like an angiogram using fluorescein as a contrast material to look at blood vessel stability and growth in the back of that eye. And they may also do ultrasounds as well. Well, during the first 3 stages, we don't really treat unless they have macular edema, okay? So what you're going to see is that what we want them to do is to continue, even though we're not going to treat in that first 3 stages, to get those exams done and to control that blood sugar. And hopefully we can delay that proliferative stage. Typically in that proliferative stage, they treat it with laser photocoagulation, very similar to what they did with the AMD. It helps to shrink those abnormal vessels. You can see that multiple sessions may be necessary. Now, they may also do what we call vitrectomy. And vitrectomy basically is used to remove the vitreous gel that may be clotted with blood from that hemorrhage. It's replaced with a saline solution, okay? What they do, guys, is they would put 2 little openings and they will take saline and flush through the eye and it drains out the other side, okay? Eye is going to be red and sensitive. They may need to wear an eye patch for a few days to protect that eye. Typically, we're going to do medicated drops, not only to protect from infection, but from protect from inflammation and swelling. Now, they can use the angiogenesis inhibitors, okay, the MABs and the NIBs, to prevent that blood vessel growth. Again, it's given by intravitreal, meaning into the eye itself injection. Now, if they do the laser photocoagulation, it is painful, both during and after that procedure. There are often spots in their vision. There may be a loss of some of the peripheral vision, and they may experience something we call night blindness, meaning that their vision in low light situations is very poor. Okay. Here is just an example. All of these little white areas are where they have lasered this eye. Okay, and you can see there are multiple sites. One of the things that you'll find is that with that photocoagulation, there is some loss of vision. But hopefully, we can keep this patient from going completely blind. Any questions about diabetic retinopathy? Okay, let's move on to cataracts. Now, cataracts, even though we think about them as a disease of the older population, that is not, in fact, the case. Some babies can be born with what we call congenital cataracts. And a lot of times that's due to the mom being infected with an STI, like syphilis. Cataracts basically are the third leading cause of preventable blindness, and they're the most common cause of self-declared visual disability in the United States. About 50% of Americans, the age 65 to 74, have some degree of cataract formation. And for people older than 75, that incidence rises to about 70%. Signs and symptoms of cataracts are decreased vision, abnormal color perception, and one of at night. So driving, you may see halos around lights, and car lights may cause a significant amount of glare. Typically, it's not a painful condition. You don't get redness from of the eye. One of the things you need to remember is that the lens itself has no blood supply. It depends on that aqueous humor for diffusion of oxygen and nutrients. One of the things that you'll see is that the most common treatment for cataracts is surgical removal. And preoperatively, what we as nurses will do is give a local anesthetic, pre-op eye drops, like a dilating drop or non-steroidal anti-inflammatory. And then that surgeon will remove that lens and replace it with an artificial lens. Typically, what you're going to see is that they usually occur in both eyes, but they don't progress at the same rate. Okay? So you may have someone with significant impairment in their vision from a cataract on one eye, say, for example, the right, but the left also has a cataract, but that lens is much less cloudy. And so light is able to get through that lens to the retina. So they don't, quote unquote, ripen at the same time. Okay. Typically, you will see a difference between the two eyes in the rate of development of cataracts. Now, these are our risk factors. Age, not much we can do about that except evaluate our older clients for development of it. But there are some things we can do about sunlight exposure, okay? One of the things that I will tell you guys is that a lot of these disease processes, sunlight and exposure to UVA, UVB rays, same thing that causes sunburn, causes eye damage. And so wearing a good pair of sunglasses, now I'm not talking about those that you get at the dollar store. You want something that's going to block UVA, UVB light. And if I could ask you to do that for your children as well, because the longer that they're exposed to those light, the more chance that they're going to develop one of these eye diseases. Now, smoking is also a risk factor. Diabetes, malnutrition, trauma to the eye can cause development of cataracts. Radiation to either the eye or the head can either start or hasten the effects of cataracts. Now, there are some medications that will increase the risk of cataract development. Number one is corticosteroids, whether it's taken as an eye drop or as a pill, okay? Phenothiazines. Remember with phenothiazines, a lot of those are our anti-nausea drugs. They're also some of our antipsychotics that are phenothiazines. Amiodarone.
We can't hear you, Ms. Hyde.
I'm sorry, what's happened? Let me see if can you hear me now?
We can hear you now.
Okay.
Yeah.
All right, let's go back. All right, so phenothiazines. A lot of them are your anti-nausea meds. A lot of them are your antipsychotics, okay? Amiodarone is a medication that we give as and they're on that medication to prevent them from developing it. Now, benzodiazepines, those are your Valiums and your Klonopins and your Ativans. Now, we're not talking occasional use here. We're talking about a prescription for that. Now, your anticholinesterases, those are your patient meds that we give for dementia. So if you think about it, a patient with dementia on an anticholinesterase, sunlight exposure as from a child that smokes that has diabetes probably is going to develop a cataract. Okay? Now, when we're talking about these meds, typically this is what we consider quote unquote long-term use. And by definition, guys, that's 4 weeks or longer. Okay? So anybody that's on a corticosteroid, think about all your patients that have COPD. The majority of them take prednisone, either 5 or 10 a day. to decrease the inflammation of their airways. Those patients with amiodarone, they'll be taking it for the rest of their life to prevent ventricular fibrillation or VTAC, either one. Those anticholinesterases are used to help decrease the decline in patients with dementia. All of those increase their risk of cataract development. Now, a little bit more about signs and symptoms. With cataract, typically it's they see either dimmed or blurred vision. Sometimes it can be distorted or double. The edges are not clear and crisp. One of the most common cataracts progressing is going to be frequent changes in those corrective lenses, meaning that you get an eye exam, you get a prescription for glasses, and then you come back in 6 months because these glasses don't work anymore. I'm not seeing well with these glasses. And they do another acuity exam with you, and you have to have a stronger prescription. Now, one of the things that will happen is that will work to a certain point, getting that stronger prescription. But it will work only to a point. The most definitive treatment for cataract is removal. Now, these patients will have increased sensitivity to glare. They typically need more light when reading. They cannot see well in low light situations. A lot of times patients will describe it like someone has put Vaseline over my glasses. There's a film over my eye. I can't see through it. Often they will have halos or rings around bright lights. And those LED automobile lights basically will throw them into a tizzy because they can't see. Typically with cataracts, you get diminished color perception as well. And so what you see is this. With normal vision, you can see how nice and blue that sky is. Through that cataract, that blue has been washed out. And there's not that much discernible difference between the white clouds and the sky. Here you see the blurred vision. Here, the tower on the left is very crisp. The one on the right is very blurry. And that's fairly common with what you see with cataracts. They cannot be treated with medication. Early stages are managed by that prescription of stronger eyeglasses or contact lenses. And like I said, that works for a while. But usually surgery is recommended when one of these three things occur. Visual acuity declines to 20/50. That patient's safety is affected, or their quality of life is affected. And those are the three conditions where either Medicare or insurance will pay for this cataract surgery. Cataract removal is the most commonly performed surgery in the United States. 99% of them are effective in improving vision. And in fact, one of the things that you will see is that a lot of these patients are able to go without glasses after their surgery. They may just need reading glasses. Now, what they do to remove the lens is this. It's a process called phacoemulsification. What they do is through a slit in the cornea, they put this probe in and break up that clouded lens with ultrasound waves. And what happens is that there is something that aspirates those particles with a suction device. Now, one of the things that has to occur is the surgeon has to ensure that all of those particles are removed, because if not, it can cause a blockage and cause an increase in intraocular pressure. Ask me how I know.
Is this the video that you had posted on Blackboard?
It is.
Okay.
That's surgery.
Yeah.
Mm-hmm. If they do cataract removal and it's required on both eyes, they typically do it 4 to 8 weeks apart, because you don't want to do them at the same time. Because trying to keep drops straight is unbelievable. 92% of our patients without any other eye disease will get a 20/40 or better visual acuity, which means that they can drive without glasses. Cataract removal is done in an outpatient setting unless that patient has major medical issues. Large majority, I would say probably 99.7 of them are done outpatient. It's done with topical anesthesia, meaning the eye drops to numb that eye, and they IV sedate the patient. Okay, usually with something like propofol. Or Versed. Because they make the incision into the cornea, those wounds do not require suture closure because that cornea will heal within 24 hours. That typical experienced surgeon takes 10 minutes or less. And I think that the video that this guy that I posted, his was 7 minutes. So it doesn't take long to do them. And it's a fairly safe procedure. What they do is they put an intraocular lens. Typically, you will see that this lens has these little wings that sort of float. It's not sutured down. It's inserted through that little slit. It's all bunched up, and then once it's out in the area of the eye, it spreads out. Now, there are a couple of types. Medicare will not pay for anything except the basic lens. Most insurances will not pay for anything other than the basic lens because they consider the restore lens, which is a lens that has the capability of focusing for distance as well as near vision, a cosmetic procedure. But there are lenses that you can get that are similar to bifocals. Now, a couple of things you need to remember. As the nurse, one of the things we are going to do is probably post-operative teaching. in these outpatient surgery areas. One of the most important things that we can do is to make sure that that patient or a family member can give their medications postoperatively. That will be corticosteroids, it may be antibiotics, it may be steroid, it may be NSAIDs, maybe eye drops. But somebody has to give them and give them correctly in order for this patient to recover from this procedure. One of the things that we are going to teach is that they should avoid activities that increase IOP, or intraocular pressure. Now, anything that causes a bearing down, like a Valsalva maneuver in order to have a bowel movement, or holding your breath, or vomiting, will raise intraocular pressure. Picking up objects that are heavy will increase intraocular pressure. Bending over to tie your shoes with that head below the waist will increase intraocular pressure. So those are activities we want to teach them to avoid. Now, when should they call the doctor or seek assistance? After the surgery, if their pain is not relieved with the analgesics. Typically, you will see that it may be Tylenol, it may be ibuprofen. They're prescribed. Some physicians will give like hydrocodone, though I will tell you that with the new prescription rules, hydrocodone is not given as often as it was anymore. If they experience bleeding, or if they experience decreased vision, those are the three complications that they need to contact the physician and be seen. Typically, they're discharged after a few hours in a postoperative period. Those medications are going to continue about 2 to 6 weeks, several times a day. We want to have them avoid those activities that increase intraocular pressure: bending, lifting, coughing, blowing their nose forcefully, trying to limit their sneezes, like holding that sneeze in. No sex for 2 to 4 weeks. No vacuuming, no sports, no driving. Typically, they avoid aspirin for pain because of the increased risk for bleeding. And it depends on your surgeon's preference as to whether that eye may be patched or not. Typically, if it's patched, it's only patched for the first 24 hours. Again, we want to prevent these as much as possible. Sunglasses, those antioxidants, vitamin E, vitamin C. Okay? Now, as I said, I speak from experience about cataracts. They gave me 1, 2, 3, 4, 5 different drops. And so this one I did 3 times a day. This one I did 3 times a day. This one I did 2 times a day. This one I did twice a day. And this one I had to take 4 times a day. This is my MAR. I had to develop one because even as a nurse, I could not keep up with what I was supposed to do. And I did this for 4 weeks. Now you can see that the antibiotic dropped off after 2 weeks. but this is 4 weeks worth of drops. This is for my right eye. One of the things that happened here is that they brought me back 2 weeks later and did the left eye. So think about this. I'm on week 3 of my right eye drops, and I started with my left eye. Well, what happened here? I had a retained fragment, and sitting at work on a Friday afternoon, my eye started having tremendous pain. And I thought, it's Friday afternoon. I don't want to go the weekend with this pain because I had a horrible headache. And of course, I was working in Concord. My ophthalmologic surgeon was in Charlotte, downtown, no less. So I drove myself down there and said, look, I've got horrible eye pain. And they did a pressure test. My intraocular pressure was 57. Normal, guys, is 10 to 21. What had happened is that fragment had blocked the outflow of my aqueous humor, and it was causing pressure and pushing on my retina. So they gave me medications to decrease my intraocular pressure and said, I need you to drive up to this address and I need you to see a retina specialist. So here I grab my car again, go to the retina specialist. And he said, when did you eat? I said, well, I had 2 chicken nuggets on the way over here. He said, well, I'm sorry about that. Other than that, I would have walked you across the street and we would have done a surgery. So now you've got to wait until Monday to get this surgery done. So they put me on some different medications to keep the pressure down over the weekend. And then Monday morning at 6 a.m., I was having a vitrectomy to remove that retained fragment, which increased the number of medications that I got on. One of the things I will tell you guys with these elderly clients, giving them a box and saying, do this 3 times a day, do this 2 times a day, do this 4 times a day, can be very, very confusing to them. So I would, sort of tell them, you may need to write it down on your calendar or write it out on a piece of paper so that you'll know that you've taken this medicine, because it's extremely important that they take these medicines after their surgery, not only to prevent infection, but to prevent swelling and make sure that eye is lubricated. Now, with patches, what I will tell you is that if the eye is patched, there is a way to do it. And let me stop sharing for just a second, okay? What you're gonna do is you're gonna take 2 of the iPads. One you're gonna fold in half, pull the eye down, place that one there, and then put the other one on top of it. That folded iPad keeps the eye from opening underneath that iPad and causing a corneal abrasion. Now, one of the things that you will see is that even if they don't patch, they will use a shield, an eye shield. It's a hard plastic that has holes for aeration. And you're going to use it in two situations. They typically use it to go home if their eye is not patched. They will also sleep with that plastic shield over their eyes. You just tape the shield on. And that's to keep them from scratching or rubbing their eyes at night. The other situation that they would wear these shields is any situation where there is air with a possibility of dust getting in their eyes. But they need to wear those shields for at least 2 to 3 weeks after the surgery, because remember how you sometimes will do this in your sleep? That raises your intraocular pressure, and that's not something we want them to do. We also don't want them itching at their eyes, okay? So those are things that you need to make sure that they are very, very well aware of. Any questions about cataracts or diabetic retinopathy? All right, I've got it's 1:52. So let's take our break and be back about 5 after. Okay?
Okay.
All right. All right. Let me share my screen again with you. Now, one of the things that I'll tell you guys is that the large majority of these eye diseases, you may not see in hospital, but this next one, you may see patients with this condition in the hospital. And it's very, very important that you remember that they need to be on medication to control that intraocular pressure. Because say, for example, they go for surgery and, you know, they have TURP, like a transurethral resection of the prostate. And they come back for surgery and someone does not rewrite for their glaucoma medication. That can be a very serious issue that can cause damage to that optic nerve and can eventually lead to blindness for these patients. Now, not over a 2 or 3 day period, but it can cause damage that can lead to it. Now, glaucoma is a group of ocular diseases that increase intraocular pressure. And what happens is that as that pressure increases, the ganglion cells of the optic nerve are damaged. A lot of times it can be classified as primary or secondary or associated, okay? Primary glaucoma is the most common. And there are 2 types of that, open angle glaucoma and angle closure glaucoma. If that pressure is not relieved or not treated, there's damage to that optic nerves that can result in permanent vision loss. Glaucoma is the second leading cause of blindness in the United States. It's the leading cause of blindness among African Americans. Risk factors, diabetes. Some of your secondary causes would be like thyroid disorder. A lot of times glaucoma is associated with obstructive sleep apnea. So patients that are diagnosed with obstructive sleep apnea need to be evaluated with their intraocular pressure. Okay. As I said, that IOP, or that intraocular pressure, is between 10 and 21. PAOG, or open angle glaucoma, is about 90% of the cases. And what you will see is that they have the drainage channels in the eye become clogged, and there's a buildup of that aqueous humor, and that pressure increases. With that angle closure glaucoma, that lens also has a buildup of pressure, but it causes the lens to bulge forward. And what you see here is that whenever you get that buildup of pressure that's unrelieved, it causes damage to that optic nerve. Now, one of the things that you need to remember about glaucoma is this: it causes a loss of peripheral vision. Remember, AMD causes central loss, but glaucoma causes a loss of peripheral vision. Here you can see at the bottom right that normal vision, and as this patient's developing glaucoma, he gets peripheral field cuts. And as it advances, that field cut increases. And when it becomes extreme, we refer to this as almost tunnel vision, because there is no peripheral vision that this patient can see. And in fact, it can be a big, big safety issue, because if this patient has no peripheral vision, think about crossing the street. They may not see cars coming at them unless they turn their head multiple ways and then ensure that there are no vehicles coming at them, okay? Typically with your patients with extreme glaucoma, they're not able to drive because of the limitation of the field cut. But these patients with earlier stages of glaucoma may be able to drive, but it can be dangerous for them because they often don't have the peripheral vision that they need in order to merge into traffic. Now, with this one, you can see that, actually, let's look at the next slide. It's easier to see. Closed angle glaucoma, where you see aqueous flow, all right, it backs up. This little angle right here, there's limitations on the flow. And then what happens is that this angle closes. This trabecular meshwork occludes the outflow of that aqueous humor. And so that's what causes the pressure to build up. In my case, what happened was that fragment occluded this area so that there was no outflow. So in open angle glaucoma, there is a narrowing and it does outflow. See here, there is that area right there that it can go out to the iris. But often what you see is that pressure builds up, but not as much as it would with closed angle glaucoma. Now, how do they evaluate it? tonometry, tonography, and gonioscopy. Okay, as I said, tonometry is a measurement of that intraocular pressure. Tonography is like a continuous reading. Think about doing a pressure reading like an EKG. Gonioscopy is the measurement of that angle to see how open or how closed it is. Now, there are several ways that they're able to do that measurement. This is probably the better way, where it's a touch. They anesthetize the cornea and then touch to the cornea to check the pressure. Okay. There used to be a way that they would do a puff of air. That one always drove me crazy. I couldn't do that. I never could keep my eyes open. But this method is a little bit easier to take. But it's a direct measurement of that pressure. Clinically, what we see with open angle, early signs is poor vision and dim lighting, increased sensitivity to glare. Often these patients will describe headache as it progresses. Their eyes get tired. Reading or watching TV or doing computer work makes their eyes very tired. These patients will have impaired peripheral vision. And if they do a peripheral vision test, it will show that decrease. Sometimes these patients will have fixed and dilated pupils. And that's due to the damage to the optic nerve, not to damage to the brain. These patients may also experience halos around lights. And again, frequent changes in their glasses prescription. The thing about open angle glaucoma, guys, that's so very, very insidious or sort of sneaky is it's painless. So a lot of patients don't know they've got this condition unless they're evaluated for that intraocular pressure. Now, angle closure glaucoma is a sudden complete blockage of that flow. We're talking severe eye pain. That sudden blurred vision, decreased light perception. People will often dilate. Along with that severe eye pain, headache, and nausea and vomiting are not uncommon because the pain is so intense. What happens is that because of that very abrupt increase, it damages the neurons of the retina and the optic nerve, and it can lead to rapid permanent loss of vision. Treatment is basically drug therapy. There are a couple of drugs that constrict the pupil so that ciliary muscle is contracted and it allows for better flow, like pilocarpine or lantanoprost. Drugs that are going to reduce the production of aqueous humor are beta blockers, like the timolols or the levobunol. Okay, they're the LOL drugs, just like the ones you learned for cardiac. Yeah, they will have some of the same side effects. Now, some of the other drugs that are going to reduce the production of aqueous humor are carbonic anhydrase inhibitors and osmotic drugs. Typically, those osmotic drugs like mannitol you would use in an emergency situation to rapidly try to get that interocular pressure down. Mannitol is usually given IV to try to get that down. Now, oh, what happened here? So, one of the things that you need to be very well aware of and teach your patient is that these medications do not cure glaucoma, but they can help control the interocular pressure and hopefully slow progression of damage and vision loss. Just like many other drugs, it can take up to 8 weeks for those drugs to reach their peak effect. And sometimes, very similar to what we have to do with other medications, is that we may have to add another drug from another class if the first drug does not give us a reduction in pressure like we want to. As I said, they either increase the outflow or decrease the formulation. Prostaglandins are probably the drug of choice for treating open-angle glaucoma. They have a very long duration of action, which means that you can give them once daily. They have a very low side effect profile. What they do is they enhance the outflow of aqueous humor and therefore decrease interocular pressure. We do not give these meds to patients with closed angle glaucoma. Zatalan is the #1 med used for glaucoma. It's a prostaglandin. Now, it can cause burning, stinging, or blurred vision. So typically we have patients to take these right before they go to bed. Now, look at this next sentence. They can cause permanent darkening of the iris and eyebrows and increased growth of eyelashes. So it is not uncommon for someone with blue or green eyes to have their eyes turn brown or brownish when they're on this medication.
I've seen that, as giving it to patients, their eyelashes are they're very nice looking and long.
Well, what I will tell you is this med, Brooke Shields commercial for Latisse.
Yes.
Same med, except in a lower dose.
Okay.
So, the Latisse, does allow for their eyelashes to grow. I mean, sometimes they almost look, like you said, they've got on the artificial eyelashes. They're very, very thick. But what more patients they don't care, eyelashes are eyelashes. And most of the time, if it's a female, that's a benefit. But the change in eye color really freaks people out sometimes. So, but prostaglandins are probably the one med that are most commonly given for treatment of glaucoma. Now, your beta adrenergic medications are given to treat open angle glaucoma. And what these do, instead of increasing the outflow, they reduce the formation of aqueous humor. Again, they can cause burning and stinging. That vision can be blurred. Now, this is a KDOD, guys. They can cause hypotension and dysrhythmias if they're absorbed systemically. So we are going to use these in caution with patients with COPD, sinus bradycardia, heart block, CHS, and asthma. Because beta blockers can constrict the bronchi and dilate blood vessels. If this patient is on a beta blocker already, it can exacerbate the effects of that beta blocker if it's systemically absorbed and cause severe hypotension and bradycardia. Now, some of the examples of these meds are betaxolol, cartilol, levobunerol. The timolol is the one that I see used most often. Okay. So,
Ms. Hyde.
Uh-huh.
So with this medication, so you're saying, so when you're administering it, isn't this where you apply the pressure on the inner canthus for?
That is exactly what my next point was going to be.
Okay, sorry.
Whenever you have a patient on these meds, you know that little hole that you got in the corner of your eye? Okay. What you want them to do is to occlude that for like 30 seconds after the eye drop is administered, and it will prevent the systemic absorption. Okay, so that whenever you put the drop in, have it occluded and keep it, you're gonna, anytime you have an eye drop, you're going to blink to make sure that it goes all the way around the eye. You would do that for 30 seconds. If you have to put the drop in the other eye, again, occlude that inner canthus to make sure it's not systemically absorbed. So that's a very important teaching point with these patients, especially with these little old folks that God knows how many hypertensives, antihypertensives they're on, because it can cause that systemic that orthostatic hypotension if it's systemically absorbed, especially if they're already on a beta blocker. Okay. So let's look at the next class. Adrenergic agonist, again, they decrease production of aqueous humor. What it does is it causes pupil dilation and increases that angle. It's contraindicated because it would cause that angle to close even more. With adrenergic agonist, these patients have to be extremely careful about any of the over-the-counter medications that they take, like cold medicines that contain pseudoephedrine or phenylalodrine, which is most of the sinus and cold medicines out there. All of those will have in tiny little 4-point type, do not take if you have glaucoma. Okay, so those are things that you need to caution them about. If they're taking anything over the counter, they need to check with a pharmacist or check with their ophthalmologist or optometrist to make sure that it's okay with their condition. Okay. Now, open angle glaucoma, sometimes they will do surgery. And what they do is a trabecularplasty where they make holes in that trabecular meshwork and allow that outflow to be a little bit better. They can do a trabeculotomy where they make a flap and it allows that humor to go out a little bit better. Cyclocryotherapy, they take a very cold probe that's touched to the sclera outside of that ciliary body, and it reduces the production of the aqueous humor. Now, typically there's a higher risk of hemorrhage if these patients are on anticoagulant or antiplatelet therapy with any of these procedures. So sometimes they may be taken off. They may not. It just depends on the physician, okay? And here you can see that flap. And so what happens is when that flap opens up, that humor goes out a little bit better. Now, our discharge teaching, again, medication administration. How do they correctly administer those meds? If they have that trabeculotomy or the any of the other surgeries, what is the post-surgical care? More than likely, it's going to be antibiotics and cortisone drops as well. With your patients with glaucoma, minimum visual exams. Every 2 to 4 years, ages 40 to 64, and every 1 to 2 years for ages 65 and older. And that includes not only visual acuity, but that pressure evaluation. Now, once the diagnosis of glaucoma is made, typically these go to every 6 months to look at the effectiveness of those medications. But at age 40, everyone should be getting their eye pressure tested in order to early detect increases in intraocular pressure. Questions about glaucoma? All right, let's talk about some eye injuries. Anyone ever had a corneal abrasion?
My sister has.
Yes, it's awful.
Most painful thing that I've ever had. I mean, you know, it's one of those things that with a corneal abrasion, you get that irritation of that superficial epithelium of the cornea, like contact lenses back whenever they used the hard lenses. Eyelashes, dirt, fingernails can cause it. They're very painful, but they do heal very quickly, usually within less than 24 hours. Photophobia, or not fear of light, but the light, absolutely, you can't stand to keep your eyes open because it hurts so much. Copious tearing occurs because that eye is trying to flush whatever that foreign body might be to get it out because it's causing damage to that cornea. Typically, they will give these patients an antibiotic ointment or an antibiotic drop for at least a week after their corneal abrasion to prevent infection. But like I said, the majority of times these things heal within 24 hours. Now, there is a difference between corneal abrasion and corneal ulceration, okay? Corneal ulceration usually occurs because of a continued irritation, okay? One of the things that we need to be very careful about as nurses is that I used to work with trauma patients all the time. And if patients come in with contact lenses on that are not extended wear, then what you're going to see is that the longer that that contact lens stays in the eye, the more likely that they are to have a corneal ulceration. You may see it also from with patients that have incomplete closure of those eyelids after stroke or head injury because of cranial nerve deficits. So those are things to think about as well. Now, other types of injury would be like burns. And a lot of times burns to the eye are caused by heat or steam. It can be caused by radiation. It can be caused by explosions or chemicals. The most common products that cause eye burns are ammonia, products that contain lye, like Drano, and acid from car batteries. Typically, these patients will have increased eye pain, decreased vision, redness on the conjunctiva, and swelling. If they have a chemical in that eye, we're going to irrigate that eye against the inner aspect to avoid direct contact with the corneal surface. And we want it to drain away from the other eye because we do not want to flush that lye or battery acid from the right eye into the left eye. So if I'm irrigating that right eye, I want that right side of the face down on the bed so that it drains away from the other eye. One of the things you want to do is that if someone has a irritant in their eye, like a chemical, they need to irrigate it at the site. And if that has not occurred, then irrigate it copiously whenever you get them into the emergency department, because flushing that eye is the best way to prevent permanent damage. Now, penetrating trauma, like metal flakes or glass or gunshots or arrows or knives, where there is a object that penetrates the globe of the eye. It can cause definite pain, partial or complete visual loss. And often what you may see is extrusion of eye contents, like the humors coming out. Now, this is one of the things that I want you to remember. If an object is sticking out of that eye, do not try to remove it. And tell your patient to keep their hands away from that object. We want to immobilize it, meaning that we may bandage that eye with that object in place until they can get them to the operating room or get an ophthalmologic surgeon there to take care of it. We're going to protect the eye, and we're also going to patch both eyes. Why am I patching both eyes?
Are you maybe taking some strain away from the good eye?
What do our eyes typically do whenever they move?
They move together, don't they?
They move together. Okay.
Yeah.
So if I've got one eye patched and someone walks in the room, that patient's going to look towards whoever walks in that room and move that other eye with that object in it. Okay. So we typically patch both eyes to keep them from moving. And we tell patients, we don't want you to move your eye. That's why we're patching both. Now, if you're patching both, you got to remember that you have to communicate with that patient everything you're doing because they can't see what you're doing. Okay? Blunt trauma is usually due to sports injuries, motor vehicle accidents, falls, physical assaults. Pain, redness, or edema is common. One of the things that you will see that is a classic sign of shaken baby syndrome is retinal hemorrhage. and that's usually due to blunt trauma. With our patients with blunt trauma, we want to place these folks in a semi-Fowler's position and patch the eye to protect it. One of the other things you may want to do is a very cursory visual examination. Okay, how many fingers am I holding up? Those types of things. You don't want to put them through a full eye exam at the initial point. But eventually they will be evaluated for vision loss and perhaps vision improvement. Now, one of the things that I see with my trauma patients quite frequently, or used to see quite frequently, are these fractures of facial bones. Okay, these are called Lefort fractures. There used to be 3 different types. Lefort 2, you can see, involves a little bit of the eye socket, whereas Lefort 3 would also involve more of the socket. And you can see the difference here with those folks. I don't see these as much anymore because of airbags. Okay. But I will tell you that with patients that are not wearing seatbelts, or with patients that are not in cars that have airbags, we still see these types of fractures. And the danger is with these bony fragments, they can pierce the globe of the eye. Now, these Lefort 3s, typically these folks get their jaw wired, and you will have major reconstruction of that face, okay? But one of the cautions that I would give you, if you got a car with an airbag, remember, those of us that are old enough to remember we were taught in driver's ed to put our hands at 10 and 2. That is not the case anymore with airbags. Should be at 9 and 3 or 8 and 4. Because what happens with that airbag, whenever you have your hands at 10 and 2, those hands go directly into your face as that airbag explodes. So you want them lower so that they don't drive those hands into your face and cause facial fractures and eye damage. Okay. All right. So sharing again. Retinal holes or detachments. There's several types. Don't worry so much about what causes those. What you need to remember are the signs and symptoms. With a detachment, you see sudden and painless loss of vision. Typically, patients that detach their retina see a bright flash of light or floating dark spots, like those big floaters. A lot of patients describe it like a pulled curtain. Think about back in the day when we were able to go see plays and the curtain would come down or the curtain would pull from right to left. And what you see is a curtain has sort of come across their vision. So it's described as that pulled curtain, bright flashes of light, and it's very sudden loss of vision. What happens is that there's a tear in the retina and fluid gets behind and it pulls it away from the back of the eye. So that light is not able to be reflected or refracted, and vision suffers. Here you can see this is a detached retina, and you can see the fluid behind it. And this patient basically had a very sudden detachment and saw flashes of light prior to having loss of vision, and then afterwards as well. Now, the way that they treat this is surgically. They can either do cryotherapy, a scleral buckle, or one of the things that you'll see that they do nowadays is what we call a pneumatic retinoplasty, or a gas bubble surgery is what the more common name for it is. Cryotherapy, basically they tack that retina back by using cold laser. We'll talk a little bit more about a scleral buckle in a minute. But a gas bubble, what they do is that they inject a bubble of gas or oil into that patient's eye, and it floats to the top and holds that retina in place, allowing it to reattach. And basically, that is tried typically before they will do either the scleral buckle or the cryotherapy. One of the things that you will see with these patients, we're going to avoid any activities that increase intraocular pressure. Eye patches and shields are common, and nausea and pain are common. One of the things we want to do is treat that nausea, because we don't want these folks vomiting. Now, with that gas bubble, it floats to the top and reattaches that retina. Well, think about it, guys. If you change positions, isn't the position of that gas bubble going to change as well? Yeah, it does. So the way that these patients are taken care of is this. They are going to sleep face down. You want them prone. This is a little device, similar to what you see on a massage table, so that the face can be not smushed into the covers, and you can breathe. So they sleep in a prone position. They position their head down when they're sitting up. This is a chair. This area right here has a hole in it so that they can see their hands. They eat. They watch TV. They do everything in this position. If they get up from this chair to go to the bathroom, they have to have their head down. And they do this for 2 weeks, hoping that that retina will reattach. Okay? So what kind of things would you, of consults, would you think that these patients would have to have?
Home health, possibly.
Home health. Who else?
Ophthalmology.
Well, definitely ophthalmology, because they're going to be following them. But where would you get all of these?
Physical therapy?
Actually, occupational therapy.
Okay.
Yeah, occupational therapy, because you probably are going to need long handle reachers. You're going to need dressing assistants. These patients often have to have someone with them just to sort of help them out, because that head must stay down for that gas bubble to stay in position for it to allow it to heal. Okay, so if that doesn't work, then they may do what we call a scleral buckle. And that is a silicone band that goes on the outside of the eye. And so what they do is they basically sew the retina to this band. And this band stays there. And I used to have a student that had one done, and you could turn, she could turn her eye and you could see the edge of the band. Okay. Again, this is something that you need to think about medication afterwards. Antibiotics, NSAIDs, steroids. These need to be taken care of in order to allow that eye to heal. Okay? Now, as a general rule, whenever you have a central field loss, and which condition did we talk about that had loss of central vision?
AMR or AMD?
AMD.
AMD. All right. Basically, these are the techniques that you teach these patients. Eccentric viewing, which means that they scan their environment. Okay, turning their head so that they can see what's going on. Give you an example. I had a student and I knew that this patient had AMD, and I just wanted to see what the student would figure out. And of course, she was using her lovely therapeutic communication techniques. She was standing directly in front of the patient and talking to her. Well, the patient would turn her head to the right. And so the student moved to where the patient turned her head. And then so the patient, as she talked to the patient again, and the patient moved her head the opposite way so that she could see her. Okay? Remember, if you stand directly in front of patients with a central field loss, they cannot see you. So objects in their environment need to be on the sides. You as the nurse, if you're talking with them, need to stand at the side of the bed, not at the foot of the bed. With patients with central loss, high power spectacles, they look almost like binoculars. Or if you've seen the doctors use like the operating glasses, they have high magnification. Handheld magnifiers or stand magnifiers are very important with these patients. But remember, they're not going to looking straight ahead. They may look to the side of what they're trying to view. Large print books and cards are important. Bold tip pens, like magic markers. Anything that gives a lot of contrast. With patients with impaired or low vision, guys, you want to have at least a 14 font, and you want typically black print on a white paper, okay? That gives it enough contrast so that they can see. Now, my comment that I said something about over-the-counter medications with a 4-point font. Typically, they do 4 or 6 point because that way they can get more information on that smaller bottle. But people with low vision or diminished vision often are not going to be able to read it. That's why a lot of pharmacies have started putting magnifying glasses that are sort of chained to the counter so that people can read the fine print. Now, there are computer systems that will work with patients with central loss as well. If they're going to be able to regain their independence in ADLs, they'll have to be able to read again. Typically, lamps should be positioned in front of the face so that it falls directly onto the page without creating glare. A lot of times, one of the things that you'll see is that if you have patients with like neurological deficits or like Parkinson's, hand magnifiers are not the aid of choice. And in fact, we would probably use a stand magnifier for those folks. Okay. So with patients with peripheral loss, and what condition did we talk about with peripheral loss? Glaucoma. A lot of it, one of those things is that loss of peripheral vision leads to night blindness and a severe loss of vision when those light levels drop. Okay, so one of the things that you will see is it's not only at night. Days like we're probably going to have tomorrow afternoon with all the rain, with no sunshine, it gives them difficulty with seeing because there's not enough contrast. Typically, your people with intact central fields they usually don't have difficulty reading, but they can have impaired visual acuity that will require that magnification. Here we want to visually scan the environment, okay? Remember, if I don't have peripheral vision and I'm out walking, I can't tell that this big dog is coming for me unless he's barking. I may not be able to see him, or I can't see that a car is coming around the corner if I'm walking. Typically with your patients with peripheral field loss, we want to have a high contrast reading and writing aids. White paper, large print, dark font, okay? One of the things that I will tell you is this: if you are doing handouts for elderly people or people with low vision loss, I don't care if it is pretty. Don't use those pinks or pastels or any of those neon colors because it does not give enough contrast for those patients to see. Again, font size should be 14 or larger for them to be able to see well. Now, I know this is a review from 101, but, I would take a look at this. How do we administer eye drops? Basically, it's better, definitely don't drop it directly on the cornea because that typically causes a blink reflex and most of the medicine goes out of the eye. Pull down that conjunctival sac and instill it there. Ask them to close their eye and move their eye around. Again, press on that inner canthus for about 30 seconds to prevent systemic absorption. Other information that you want to give clients is don't share eye drops with others. Definitely don't touch the dropper to your eye. And keep eye drops separate from other bottles. Keep eye drops separate from other bottles. One of the things that I will tell you guys is that a lot of your ophthalmic medications have different color tops based on the type of medication they are, so that you can easily recognize them. But have any of you ever done like a hemoccult test for stool?
Yes.
Okay, the dropper for that looks very similar to an eye drop bottle, doesn't it?
It does.
Okay, and I have had patients that get confused when someone placed that hemoccult bottle at their bedside. And that's one of the things that I always tell people, don't do that, because hemoccult in developer in someone's eye is something that you're going to have to irrigate and irrigate and irrigate to get it out. If they wear contact lenses, they should remove those lenses before using their eye drops. Wait at least 5 minutes and then put them back in. We do tell patients that they should wait 5 minutes in between eye medications to allow for full absorption. Now, I've got a big X on this Visine bottle. What is Visine?
Normal saline?
Not really.
It's
Part of it is normal saline, but
eye redness and irritation.
it gets the red out, right? Okay, how does it get the red out?
It constricts the blood vessels.
It constricts blood vessels. And that's one of the things, especially with our patients with glaucoma, we don't want them doing. Okay, so typically, other than normal saline, other than something for dry eyes, they need to check before they use any over-the-counter medications. Okay? So that's my spiel on eye stuff. Any questions? All right, let's take another break and we'll finish this up. We will not go to 4, okay? So I'll let you out a little early today.
Okay, thanks.
All right, so be back at about 10 after. Now, one of the things that we see as part of the sensory perception is neuropathies. Now, I know that you guys learned a little bit about peripheral neuropathy whenever you talked about diabetes, but there are other types of neuropathies as well. So let's do a quick review of peripheral neuropathy. Usually that's when a trauma or disease interferes with the innervation of peripheral nerves. And so what you will see is that the blood vessels decrease, okay? And so that what you're going to see is that you have a patient that, because of their diabetes, has less effective blood vessels. And what happens is that those blood vessels constrict and divert blood to larger vessels. And so what you get is peripheral tissue that doesn't get a good blood supply. Now, one of the things that they feel that causes peripheral neuropathy in your patients with diabetes is because of that decreased blood flow, that the blood does not allow for the distribution of B vitamins to those nerves. And B12 and B6 and B1 are good vitamins that support nerve growth and nerve function. And so because of that decreased blood flow, they don't get those vitamins. And in fact, some physicians, some endocrinologists are starting to supplement their diabetic patients with B complex in order to try to reduce or to prevent development of peripheral neuropathy. So,
Ms. Hyde, real quick, sorry. You said it has to do with B complex deficiency? Okay, thank you.
Because the blood vessels can't get those B vitamins to support the nerve function to those peripheral nerves.
Got it.
Okay, when you're talking about polyneuropathy, polyneuropathy means involvement of more than one nerve. Diabetes is the most common cause. It's basically, typically you see that those funny feelings of pins and needles appear in the toes and feet and then progress upward. Okay, so that's a polyneuropathy. So what you have is numbness or tingling. Some patients describe it as aching or burning or shooting pains, and they have cold feet, and it's because of the lack of blood supply. They can have weakness or paralysis if the motor nerves are affected. And some patients, they will have a neuropathy of the autonomic nerves that innervate the bowel or bladder. Some other sensations that you may see that are impaired are sensation of pain and temperature and light touch, 2-point discrimination, vibration. With these neuropathies, there's no specific treatment. Now, a lot of patients use like pregabalin or gabapentin, like Lyrica, or those types of meds to help control the pain. But those medicines do not treat the neuropathy. Now, mononeuropathies are isolated peripheral nerves that have a damage. Probably the one that we think about most commonly is patients with carpal tunnel, okay, where they have a compression of the nerve that runs through the carpal bones. And what they get is numbness and tingling in their fingers. And eventually they will get decreased function of the motor nerves in their fingers where they cannot hold objects like a cup or a spoon. A lot of your mononeuropathies are caused by excessive motion. Now, some of the others are third cranial nerve palsy, like the ocular motor palsy, that headache, eye pain, that inability to move the eye up and down or medially. Okay, radiculopathies are pain that occurs over a dermatome, most oftenly associated with like slip disc, or you may see it associated with a disease process like shingles. You may see the femoral diabetic femoral neuropathy, where you will have pain and weakness in that anterior thigh and medial calf. Now, that entrapment or compression of the nerve, that carpal tunnel that I talked to you about, you may also see it from foot drop, where you have a peroneal nerve at the head of the fibula that is compressed. Okay. Common causes, trauma, the pressure on that nerve, motor vehicle accidents, falls, sports injuries, hitting your funny bone, okay? Basically, that is a trauma to that nerve that runs through the elbow. Diabetes can also cause neuropathies. A lot of your autoimmune diseases like lupus or RA, okay? Your vitamin deficiencies, like I said, the B vitamins, or patients that abuse alcohol. Remember, thiamine is one of the things that they lack, and thiamine is a B vitamin, and it often causes neuropathies. Now, you can see it from Lyme disease or shingles, tumors, poisons like lead or mercury can cause damage to those nerves as well. Now, how do they treat them? Typically, they will give an anticonvulsant like gabapentin or Topamax or pregabalin or carbamazine or phenytoin, okay? There is a theory that these types of pain syndrome are like a seizure of the nerves, and that's why these medicines work to decrease these pain. Now, again, as I said, the gabapentin level, the phenytoin level is much, much less than what you would give with someone with seizures. You may see them use lidocaine patches. It's a topical anesthetic. They apply that to where the pain is most severe. But with lidocaine patches, one of the Cadiotes guys is this: it can only be left on for 12 hours because you develop tolerance to that. You have to put it on 12, off 12 in order for it to work. They can also use some of the tricyclic antidepressants. It interferes with the perception of pain. You may see them use some of your SSRIs for peripheral neuropathy caused by diabetes.
Quick question, Ms. Hyde.
Uh-huh.
For the treatment, do we just need to know that like anti-seizure meds, lidocaine patches, and antidepressants can be used?
Yep.
Specifics?
Yep.
Okay, thank you.
So one of the other things that you may see used are TENS units, transcutaneous electrical nerve stimulators, where you have electrodes placed on the skin and low electrical current is delivered at varying frequencies. And it helps to decrease the pain stimulus. You know, those things that Shaq is advertising. He's got his hand in pretty much everything from insurance to pain control. But TENS units, like this particular type, you can buy at CVS, and it works extremely well because what it does is it sort of blocks the signal for pain from that nerve by stimulating the skin. And so what you feel is the skin stimulation instead of the nerve pain, okay? Now, you can't leave these on all day long because, again, you do develop tolerance. Typically with TENS units, they recommend no more than 2 to 3 times a day for about 15 minutes, but they can be used. Just general good client education. If you got diabetes, take care of your feet. Check your feet daily, wear good shoes, inspect on a daily basis. Exercise regularly. It increases the circulation. Remember when Ms. Rumble talked about arterial and venous disease? You know, even though with arterial disease, it hurts to walk, that's the treatment of choice because what it does is it increases that circulation. we have them stop smoking because it is a vasoconstrictor and will further lessen the blood flow to those peripheral nerves. And then definitely eat that healthy diet, adequate vitamins, adequate minerals, and perhaps supplements based on whatever your doctor's philosophy might be. Okay? Other client education, we don't want them to cross their legs, lean on their elbows, or type or do any action for long periods of time without a break. Because a lot of these neuropathies are due to repetitive stress. We want them to keep their blood sugar under control if they have diabetes, because it can exacerbate the problem. Nursing diagnoses that we see, probably the most commonly that would be priority, that acute pain or altered comfort, that impaired tissue integrity, and then knowledge deficit as well. All right, so let's move on to ears and hearing. Just a few changes that I want you to know about related to aging. As we age, our cerumen or earwax becomes drier, and it more likely impacts or occludes our ear canal. As we age, we also lose tympanic membrane elasticity. Remember, it's that tympanic membrane moving with those sound waves that allow us to hear. Those bony ossicles, that hammer, that anvil, that stirrup, are less likely to move because they decrease, they ossify. There are also degenerative changes in the cochlea, which are going to affect our balance because it causes disturbed vestibular function. As we age, we have diminished hearing ability. And with our elderly clients, they typically have a decreased ability to hear high frequency sounds. Okay? And so what you see is that a lot of times your elderly population will have trouble hearing children's voices or women with high-pitched voices. I can remember one student that was taking care of this patient over on post-surge 2. And I swear she sounded like Minnie Mouse on a good day with that squeaky voice. And I was down the hall and I hear, "Mr. Wilson, I need you to get up out of bed." Patient she was taking care of had had a hip replacement. And all of a sudden I hear, "What, little girl? I can't hear a word you're saying." So she started yelling, "Mr. Wilson, I need to get you out of bed." I still can't hear what you're saying. Okay. One of the things that you will see is that a lot of times when we raise our voice, the pitch goes up. If you lower the pitch, patients with hearing difficulties are more likely to be able to hear you. So after about 3 Mr. Wilsons, and the whole unit is dying laughing because every time she said, "I need to get you out of bed, little girl, I can't hear a word you're saying," I go in and say, "She needs to get you out of bed." "Well, why didn't she say so?" So one of the things you'll see is that those folks will have different abilities to hear. Now, the other thing that you see is that they also typically lose some of the ability to distinguish some of the consonants, the t, the k, the p, the sh. Those types of sounds are lost. So instead of that, it would be at. So their hearing is going in and out. Now, why do they have changes? Well, most of them is because of wear and tear. But sometimes it's due to something that we call ototoxicity, where they may have tinnitus, okay, which is the ringing in their ears, and sensorineural hearing loss. That's due to cochlear toxicity. With vestibular toxicity, you may see lightheadedness and weakness, meaning their balance is off. Now, some of the risk factors for ototoxicity are renal or hepatic disease or insufficiency, the use of 2 or more potentially ototoxic drugs, dehydration, bacteremia, and the use of ototoxic drugs with nephrotoxic drugs. Okay? So some of those things are directly related to aging, because remember, as we age, our renal and hepatic abilities decrease. Okay? Now, we are also exposed to more drugs and may take a more variety of drugs that may be ototoxic. So let's look at some of those drugs that may be ototoxic. Antibiotics: gentamicin, streptomycin, neomycin, tobramycin, vancomycin, chloromycetin, and erythromycin. What do those all have in common?
They're antibiotics.
They're antibiotics, but
Mycin.
they're mycin drugs.
Yeah.
If it says mycin, think of ototoxicity.
Okay.
Okay? Diuretics like Lasix or furosemide or Diamox, acetylcholine. Okay? Diuretics, as a rule, can be ototoxic. Some other drugs: aspirin, alcohol, quinine, and cisplatin. Okay? Cisplatin, of course, is a chemotherapy drug that they typically use for kidney cancer. They can use it for other types of cancer as well. But all of these drugs have ototoxicity. Now, let me give you another KDOT, guys. If it is an ototoxic drug, 9 times out of 10, it can also be toxic to the kidneys. Why? Well, if you look back at your fetal development, the ears and the kidneys form about the same time. And so there are many commonalities between those two sets of organs. So if I have a patient on vancomycin or gentamicin, I'm extremely worried not only about that patient's hearing, but What is their kidney function? Lasix acts directly on the kidneys to the point where it pushes the kidneys to release more water. It's a diuretic. Eventually, it will stop working on the kidneys and the kidneys will not respond to it, despite higher and higher doses. So think about that whenever you're thinking about meds that are ototoxic. If it causes renal disruption, I would be very careful and assess this patient's hearing as well, okay? So any of you that have had kids know that sometimes foreign bodies end up in ears and noses where they really shouldn't be. Earwax, probably one of the most common causes of decreased hearing in our elderly population. Foreign objects like gravel or peas or insects. Y'all ever watch that show about life in the ER on Lifetime Channel or one of those TLCs or one of those random cable channels?
Yeah.
Yeah. There's one that if you get a chance to watch it, it's really sort of interesting. This woman comes in and they think that she's a psych patient because she keeps saying, get it out, I can hear it, get it out. And of course, when they're examining her, they can't see anything and they think that she's having a psychotic episode. And then unfortunately, someone does, they call psych, but then someone does happen to look in her ear and there's a beetle in her ear. And what she literally was hearing was that beetle on her eardrum. And that was, mimicking that psychosis in that patient. One of the things that you'll see about insects, as a general rule, we kill the insect before trying to remove it. And the best way to do that is drown it with mineral oil. Okay? And then you flush it out with saline. Now, one of the things you have to be very careful about is vegetable matter. Dried peas or dried beans, we do not want to try to flush those out, because what happens when water goes to a dried vegetable?
It swells.
It swells. And so you're going to have a worse problem. Okay. So if you have a foreign body, a lot of times earwax, they will use a device that looks very similar to a water pick to irrigate those ears. Foreign objects, typically we use a pair of forceps in irrigation. Insects, kill the insect because you don't want it moving around in there, because that leg scratching the eardrum and the ear canal can cause major damage. Okay, so if with that foreign body, we want to get it out. Now, when you're talking about Meniere's disease, there are a couple of terms I want you to be very straight with. Dizziness is a sensation of imbalance, unsteadiness, or faintness. It's sometimes associated with giddiness, weakness, confusion, or blurred or double vision. Okay, think of this as our patients that may have orthostatic hypotension. They don't have enough blood going up into their head. Now, vertigo is different. It's a sensation of revolving in space or surroundings that revolve around you. Okay? You whirl, so to speak. You feel like you're going to fall off the edge of the earth. Meniere's disease, classic sign is a paroxysmal whirling vertigo. Paroxysmal means it starts suddenly, stops suddenly. Typically, these patients will have a fluctuating sensory neural hearing loss and tinnitus or tinnitus that is louder preceding and during an attack. And they have pressure or fullness in the ear. So when patients that have Meniere's disease have an attack, they get that roaring sound, that tinnitus. Their ear feels like it needs to pop, and their hearing decreases. Now, in the early stages, that sensory neural hearing loss is transient, meaning it sort of comes and goes. But as the disease progresses, that sensory neural hearing loss can become permanent. Some of the triggers: salt, caffeine, alcohol, stress, allergies, menstruation, changes in barometric pressure. It's a low-pitched roar or humming sound that worsens just before a severe attack. And that humming or roar is a warning sign that these patients need to get to a place where they can lie down. Otherwise, they're going to fall over. What we do is we try to relieve the symptoms. We put these patients on bed rest. Side rails up to keep them safe. And then we give meds to control that vertigo, typically Anavert or diphenhydramine. And we control the nausea with something like ondansetron or phenothiazine, like Phenergan, promethazine. One of the ways that we try to prevent this is put them on a low sodium diet with a fluid restriction to try to prevent the attacks. My brother has Meniere's. He said the only nice thing about it is that when you go to McDonald's and get French fries and ask for no salt, you get hot fries. And I'm thinking, why bother? That's what the best thing of the McDonald's fries is the salt. But typically what we do with these patients, low sodium diet, fluid restriction, some patients are placed on a diuretic, a low milligram diuretic to try to keep that fullness out of their ear. Now, a labyrinthectomy is the last resort to control that vertigo, because unfortunately what happens is that to do that labyrinthectomy causes permanent deafness in that ear. About 80% will experience improvement with management. Diazide, Valium, Anavert, prednisone are things that they would use. Typically during an acute attack, they may be given atropine to decrease autonomic dysfunction. That should be ADN, autonomic, not AND. Seriously, with the labyrinthectomy, those are usually done when hearing loss has become so profound that it will not be a loss to lose the rest of the hearing. All right, so.
This was a lot.
It is a lot.
Oh my God.
So let me stop this. and look at some of the comments. What would you say are some of the main topics or info to narrow down our studying for the test? Please and thank you. Just trying to do well. I need more Katiotes. All right. Well, I will tell you this. I have got a set of questions, practice questions for you guys, and I will open that up as soon as I get finished with the lecture.
Oh,
Someone's asking me to tell them all the questions.
yeah, that was me. Thanks.
No,
Let me just get it.
I can give you all the answers.
Yeah, give me the answers. I'll match it to the question.
A, B, C, or D, or sometimes A, C, and E, or
Oh,
things like that, you know. But I will tell you that focus on nursing care. Okay. On your patients with glaucoma and patients with seizure meds, glaucoma meds, seizure meds. What would I teach the patient? My questions are going to be focused more on nursing care and nursing education. Okay. What would I do in caring for this patient? What's important information for me to know?
okay.
I have a question, Ms. Hyde.
Yes.
I know you said that the medications for seizures are fair game. I just have a question about the side. We are responsible for the side effects for each medication.
Well, what I would tell you is think about safety with some of those. Okay. If I tell you that, you know, dizziness or, you know, decreased level of consciousness can be a problem with those patients, then definitely, you know, listen to what I'm saying. You know, if I say something more than once, it's an important concept. And if you go back and listen, how many times did I talk about gingival hyperplasia and brushing and flossing and things like that? Okay. So what are specific nursing care things that I'm going to have to do? What is my role in caring for that patient with a seizure? I'm going to observe what I see and document that for the healthcare provider, and I'm going to protect that patient from injury. My two priorities for that patient. Okay. Any other questions that you can think of?
I think Becca may have asked this at the beginning, but I kind of hopped on a little late. But as far as like the seizure medications, I know they have like a lot of interactions. Do we?
No, don't worry about interactions.
Okay.
Yeah, it's like I said, you know, if you look at Coumadin as a drug, there are over 6 pages of interactions. The majority of time, what you're going to do is check it in MicroMedX and see if there's an interaction there. And it will also come to you whenever you are working with these medicines quite a bit. I mean, you know, I'm concerned if they put a diabetic on phenytoin because it can really screw up blood sugars. You know, I'm worried about patients with liver failure or liver insufficiency with a lot of these anticonvulsants because they are metabolized in the liver and cleared by the kidneys. And so patients with either kidney or renal dysfunction, you have to be careful about doses because then you need to check what their therapeutic levels are. Because if you don't metabolize it in the liver, that level is going to go sky high. And then you're going to see major side effects. Okay?
Thank you.
Yes. Mm-hmm. Yeah, amiodarone is a medication that we give to patients with cardiac dysrhythmia called ventricular fibrillation or ventricular tachycardia. Okay, those are two lethal rhythms. And we use amiodarone to sort of keep them from going into those. Typically, you'll it could, but they're going to have to take it because if they don't, they're going to die. So, that's something they're just going to have to know.
So is that more so like on a patient teaching standpoint? Is that?
Well, what you would want to do with that, Tracy, is to do this, is if they're on that medication, make sure that they're getting yearly evaluations of their eyes.
Got you. Okay, thanks.
Just like with your diabetics, you want every 6 months with those patients to rule out the development of retinopathy, especially those patients that have been diabetic for more than 5-10 years or more.
Okay. Thank you very much. That helps out.
Okay. Like I said, I will post those questions. And I will let you know, guys, tomorrow I am in simulation all day, so I probably will not be available to answer questions until late. But if you guys are studying, Friday I will be sitting right here at my computer. Saturday and Sunday, if you come up with questions, text me. And if I can answer it via text, I will. If not, I'll tell you to check your email because I have old fat fingers and texting is not something I do very quickly. So I type a whole lot faster. So, especially on the weekends, I don't check my email that often, but I do check my phone. Okay?
Sounds good. Thank you
All right.
so much.
All right. I will post the recording as soon as it gets converted, and I will open up those questions. What I would tell you guys is do your studying and then look at those questions. Okay? And then check your knowledge. Use it sort of as a study tool. If I get this question wrong, then perhaps I need to go back and look at something else like that. Okay?
Okay, thank you so much.
All right.